Hi, this is Nursinga, and you are watching an after-class review of fluids, electrolytes, and acid-base balance. Our bodies are made up of roughly 55 to 65% of water. And water, when it's dissolved or has suspended substances in it, like glucose, protein, ions, and cells, is called fluids. Those ions are referred to as electrolytes. So these are mineral salts that dissolve in water and separate into ions. And they can either be positively charged or negatively charged. So a positively charged particle is called a cation, and those are sodium, potassium, calcium, and magnesium. A negatively charged particle is called an anion, and those are chloride, bicarbonate, and phosphate. About 65% of the fluid in our body is found inside our cells. The other 35% is extracellular or found outside of the cells. Of that 35%, 25% is interstitial or between the cells. 8% is intravascular inside our blood vessels, and 2% is transcellular, and that includes things like the fluid in your eyeballs and your cerebrospinal fluid. And of note, the 25% interstitial also includes our lymph. Homeostasis is the state of balance that our body constantly strives to achieve. And therefore, water and ions are constantly in a state of flow, moving between these intra and extracellular and stitial spaces. And ions can move passively by diffusion from a high concentration to a low concentration just by chance, by bouncing around within the cells or within the vascular space, and they reach these open ion channels and just pass through. Ions can also be moved by active transport, which requires ATP, and this moves them from a low to a high concentration to create a pressure gradient. And a great example of active transport would be our sodium-potassium pumps that are used to reset the resting membrane potential. Water moves passively by osmosis, and that's from a low concentration to a high concentration. So it goes against the concentration gradient to dilute the high concentration. And that occurs when ion channels are closed and the salts can't move. The goal is, again, homeostasis and just to equalize this concentration. So diffusion and osmosis will keep ions and water balanced. Active transport resets cell membranes. The other thing we need to talk about is filtration. Filtration uses hydrostatic pressure at the arterial side of the capillary beds to force plasma and ions, electrolytes out into either the kidneys or the interstitial spaces. So it's going from a very high pressure to a low pressure system. Then on the other end of those capillary beds, on the venous side, the colloid pressure or oncotic pressure created by having a lot of proteins and glucose and cells, like red blood cells and white blood cells, inside the bloodstream, pulls that fluid back in. So it kind of creates a siphon or a vacuum where it attracts the fluid and pulls it back into the bloodstream. So edema results from an error in filtration. We talked about this a lot in class, but we have crystalloid type of fluids, which are just water and ions, electrolytes. And those are used just to replace fluid within the body. So if the body is dehydrated and you need fluid that can easily move between your intravascular and your interstitial and your intracellular spaces, something like a crystalloid is the perfect fluid for that. Colloids, like albumin, create oncotic pressure and increase the intravascular volume. So if I have somebody who's getting a lot of third spacing and edema and their albumin levels are low, I might want to give them something like a colloid to increase the oncotic pressure, which will pull fluid back into their blood vessels. Now, we also talked about using that mechanism for things like mannitol, which is an osmotic diuretic, and the fact that patients in DKA have that happen to them without even wanting it to. But colloids or any large molecules are going to pull water back into that vascular space. And then red blood cells would be like, giving somebody a blood transfusion would be the only way to really enhance oxygen carrying capacity, which neither crystalloids or colloids can do. When the filtration system doesn't work at the capillary level, we see edema. So when you see edema, start thinking to yourself, I wonder what's going on. Is there damage to the capillary beds? Is there a problem with the amount of colloid available to pull? Is there a problem with the pressure and the amount of hydrostatic pressure pushing out? Fluid intake and absorption is impacted by the amount that's taken in PO, by fluid and foods, G-tube feedings, NG-tube feedings, OG-tube feedings, even IV. Thirst is triggered by hypovolemia, increased blood osmolality, so if it's too viscous, it's too thick, the body wants to thin it out, and decreased blood volume. Fluid distribution is mediated by filtration, which we just talked about, between the spaces, the kidneys, and then the vascular and interstitial spaces, and osmosis between cells. And then fluid output is regulated by usually the kidneys. So that's sensible losses by the kidneys in terms of urine output. But then also we could measure diarrhea or vomiting, so MSS losses. Insensible losses include things like the respiratory mist, the humidification that you lose through your respiratory tract as you breathe, and sweat. So thinking about that, if I have a fever and I am sweating, or if I have a fever and my respiratory rate increases, my insensible losses are going to increase. So patients who have febrile illness are at greater risk for fluid volume deficit. Fluid balance is then this kind of tricky game of constantly trying to not put out more than you take in, but the kidneys are actually getting rid of salt and water follows salt. So sometimes the kidneys have to get rid of some salt and the water's just going to follow it. Clients who are at risk for fluid volume imbalances include patients who are either really old or really young, people who have an extensive medical history, the environment that they're in, too hot, their diet, their nutrition, and the medications that they take, especially if they're taking diuretics. Fluid volume overload looks like somebody who's gained weight, they're hypertensive, tachycardic with a bounding pulse, they have crackles, they're short of breath, they're orthopnic, they have pitting edema and jugular vein distension. Fluid volume deficit, on the other hand, the patient has lost weight, their blood pressure is low, and oftentimes they get orthostatic when they stand up, they get lightheaded and dizzy, or they might even pass out. They have tachycardia and tachypnea, but they have those weak, thready pulses now, not bounding pulses. They have poor or tenting skin turgor, dry, cracked mucous membranes, and scant, dark urine. The patient with fluid volume overload is hemodiluted, and their H&H is going to look low on lab work because they have so much extra fluid in the bloodstream. The patient with fluid volume deficit is hemoconcentrated, and their H&H is going to look high due to the dehydration. Fluid balance in children, specifically dehydration is our major concern, is when output exceeds intake. The causes for this are the same as for adults: diarrhea, sweating, medications, DKA, vomiting, again, infection and fever because of the increased respiratory rate, diuretics, trauma, NPO status. And a newborn being NPO for more than 4 hours can put them into fluid volume deficit. and then burns, because burns cause significant third spacing and fluid loss. Signs and symptoms include those dry, cracked mucous membranes, sunken orbits, sunken fontanelle, tenting skin turgor, tachycardia, hypotension, thirst, weight loss, oliguria, which is decreased or almost no urine output, so very scant dark urine again, and lethargy. You'll notice I put a picture up here of a little baby who has tenting turgor. Now, on an adult, we like to check it up on the chest, kind of like above, just below the clavicle, but above the breast tissue. So like the first or second intercostal space, mid-clavicular line, really on either side. On the child, you can do it on the abdomen, as you see here. So the treatment really is to maintain fluid and electrolyte balance, replace volume deficits. In kids, everything is weight-based, so we start out with 20 milliliters per kilogram fluid boluses. It's really important that we use pumps in little kids because just going a little bit too much over or under could have a significant impact in their outcomes. And potassium is only used in kids once the urine output is adequate. So that you rehydrate these kids before you start giving them potassium, because their kidneys are not well developed to clear potassium if you overshoot. But the main goal for fluid balance, really in everybody, is to treat the underlying cause so that it doesn't continue. In the elderly, they are at the greatest risk of fluid volume deficit because they have a lower percentage of body weight normally, so they're not at that 55 to 65%. They have a decreased thirst mechanism, and they might even have difficulty obtaining fluids if they have impaired mobility, or they might avoid drinking adequate fluids even if they're thirsty if they have an issue with elimination. They may be taking medications that increase fluid excretion, such as diuretics. The three hormone processes that you should be familiar with in terms of fluid balance are ADH, the RAS system, and the natriuretic peptides. So ADH is antidiuretic hormone, and that tells the kidneys to retain water and increase blood volume. So it says don't allow any additional water to escape. The RAS system is triggered by the kidneys, and that kind of activates the renin released by the kidneys, activates the RAS system, which ends up releasing aldosterone, ADH, as we just saw, and then it also has some alpha stimulation effects on the arteries and on the kidneys to decrease renal perfusion, to increase peripheral vascular resistance, and aldosterone specifically holds on to more salt and water in the kidneys. So all of this together between the ADH and the RAS system really increases circulating blood volume, especially the volume that's available in the core. Now, the safety mechanism for all of this is ANP, and ANP is the atrial natriuretic peptide, and that is kind of the safety mechanism within the heart that says when preload gets too high and the stretch in the myocardium gets too far, so that we don't tear myocardial muscle tissue, the ANP releases a signal that tells the kidneys to start releasing water again. So that's kind of a safety mechanism that is in place there. So solutions are classified as either isotonic, hypotonic, or hypertonic. Isotonic solutions, when they are introduced into the bloodstream, do not have any significant effect on fluid or electrolyte movement. Hypotonic solutions, however, can cause a drastic fluid shift towards solutes. So it goes towards the salts, it goes towards the proteins, it goes towards the glucose. As you can see in this example here, the red blood cell goes from looking more like a donut to looking more like a cherry. So if you can remember the O in hypotonic, the cell gets overloaded and it can actually even rupture or burst, which is called hemolysis. And our concern there is that the contents of the cell are then emptied into the bloodstream or the whatever space they're in, but the potassium is released from inside the cell, and that can cause significant electrolyte imbalances. In a hypertonic solution, the cell actually shrivels up, so the fluid exits the cell. So if you can remember the E in hypertonic, the fluid exits the cell. And this kind of creates this shriveled cell that can't carry oxygen. It's really no good actually at this point if it's a red blood cell. This is called crenation. And then these little cells are set on a path of destruction. The spleen will pick them up, break them down. All right, let's talk about some of our electrolytes now. So the electrolytes that you need to know are sodium, potassium, calcium, magnesium, chloride, bicarbonate, and phosphate. That's it. I recommend that you make the flashcards for these, that you write down the normal ranges on some flashcards so that all you're thinking about are normal ranges on some of them, and then you do the, hyper and hypo on other flashcards. Don't put too much information on any one flashcard. Sodium is our primary extracellular cation. Potassium is our primary intracellular cation. Chloride is the primary extracellular anion. And you can see these by the lab values, kind of what's going on with these. Magnesium and calcium are both kind of in and out of the cells. But calcium and phosphate have this interesting relationship where if calcium goes up, phosphate goes down, and if calcium goes down, phosphate goes up. So that's kind of a definite. If one is high, the other is low. So you definitely want to know the ranges for those so that if you can see like if phosphate is elevated, then it's going to cause hypocalcemia, or if calcium is elevated, it's going to cause hypophosphatemia. So the normal range of sodium is 135 to 145. When it's below 135, it's considered hyponatremia. And this usually is caused by consuming too much water or losing too much salt. The osmolality decreases, and the patient experiences lethargy, headache, and confusion. Sodium causes seizures. So whether it's too low or too high, connect the S in sodium with the S in seizures. You're going to have altered mental status, seizures, and our major concern is safety, so we should put on seizure pads. You should also have out all of the airway management equipment for that patient. A sodium greater than 145 causes hypernatremia, or is called hypernatremia, and this is when the patient has a decreased water or excess sodium and the osmolality increases. They experience fever, restlessness, hypertension, edema because water follows salt, and dry mouth. Altered mental status, seizures, and our major concern still is safety. The treatment for both hyponatremia and hypernatremia is actually usually sodium chloride. With hyponatremia, that they oftentimes just treat it with normal saline. The same thing with hypernatremia, and then trying to get everything kind of under control and balanced. But once the person is adequately hydrated, usually the kidneys will take care of it. The normal range for potassium is 3.5 to 5. Hypokalemia is less than 3.5, and the patient usually has a history of diarrhea, vomiting, GI suction, alkalosis. So alkalosis actually, to buffer for alkalosis, more potassium is forced into the cell, and the hydrogen ions leak out of the cell. So alkalosis, being an alkalotic state, actually causes hypokalemia and hypocalcemia. Potassium wasting diuretics and excess insulin because insulin picks up potassium as it's putting the glucose into the cell. The patient presents with muscle weakness, constipation, and cardiac dysrhythmias. All potassium patients should be on a cardiac monitor. And remember that potassium is kalemia, so think of K cardiac. A patient with a potassium greater than 5 has hyperkalemia, and this is usually caused by increased PO or IV potassium, cellular damage, like we're talking about with fluid volume overload, or crush injuries, or burns, lack of insulin, kidney failure, and potassium-sparing diuretics. Now, you'll see kidney failure with a lot of these, but it's because the kidneys are primarily responsible for filtering out the ions and maintaining adequate electrolyte balances. Muscle weakness, diarrhea, and cardiac dysrhythmias. So you notice when your potassium gets high, you have diarrhea. When your potassium gets low, you have constipation. Again, the patient with a potassium imbalance must be on a cardiac monitor. If the patient has hypokalemia, we do potassium replacement therapy, and only slowly. You never bolus potassium. On a regular medical surgical floor, it's typically no faster than 10 milliequivalents per hour. If the patient is in a critical care unit, 20 milliequivalents per hour on a cardiac monitor. And under only extreme circumstances, and usually only with a central line, we can go up to 40 milliequivalents per hour. For hyperkalemia, there's a lot that we can do. We can do continuous epidural nebs. We can do a glucose insulin drip. And then we can do drugs like K-Exolate. And K-Exolate was one of the drugs you were looking up this week. So I will let you research how that one works. Calcium has a range of 8.4 to 10.5. Below 8.4 is hypocalcemia. This is usually caused by nutritional deficiencies, specifically vitamin D deficiencies, again, kidney failure, chronic diarrhea, alkalosis. With alkalosis and calcium, the calcium binds to albumin in an alkalotic state, and therefore there's not enough free calcium floating around in the bloodstream. Laxative use, hypoparathyroidism, and blood transfusions all cause hypocalcemia, and also hyperphosphatemia would cause hypocalcemia. The patient presents with numbness, tingling, hyperreflexive muscles, Chvostek's and Trousseau sign, and tetany. And remember, Chvostek is the facial twitching of the facial nerve, and Trousseau sign is blowing of the blood pressure cuff, leaving it there, and the arm spasms. A calcium greater than 10.5 is considered hypercalcemia, and this usually occurs from prolonged immobilization, hyperparathyroid, hypophosphatemia, bone tumors, and thiazide diuretics. And all of this is because the bone usually is getting broken down faster than it's getting remodeled. The patient presents with anorexia, nausea, vomiting, constipation, loss of reflexes, lethargy, and cardiac arrest is possible as well. The treatment for hypocalcemia is calcium replacement. The treatment for hypercalcemia is usually fluid resuscitation to dilute things, and then depending on the cause, there's some different medications we can give, but sometimes we do binding medications, and at worst case scenario, they might need something like dialysis. For phosphate, the normal range is 2.7 to 4.5. Hypophosphatemia is usually caused by malnutrition, hypercalcemia, hyperparathyroid, or excessive antacid use. The patient has the same signs and symptoms as hypercalcemia, because again, it's an inverse relationship, so lethargy, weakness, anorexia, and nausea. With hyperphosphatemia, the level is greater than 4.5, and we usually see this in patients who have kidney failure, hypoparathyroidism, DKA, and rhabdomyolysis, as well as the hypocalcemia. Typically asymptomatic, but they develop signs and symptoms of hypocalcemia when it becomes severe. Magnesium's normal range is 1.5 to 2.5, so it's really, really low. And with hypomagnesemia below 1.5, the patient usually has had a history of malnutrition, chronic alcoholism, chronic diarrhea, laxative use, or thiazide diuretics. Chvostek's and Trousseau sign may be positive during hypomagnesemia. Hyperactive reflexes, muscle cramping, and seizures are all possible with hypomagnesemia. Hypermagnesemia exists when the magnesium level is greater than 2.5, and we usually see this when somebody has used too many magnesium-containing laxatives or antacids, and with end-stage renal disease. Now, if the person has end-stage renal disease, they will need dialysis as a treatment. Lethargy, loss of reflexes, respiratory depression, cardiac dysrhythmias, and cardiac arrest are all possible with hypermagnesemia. And you know as a nurse that one of the things that you have to do is keep a careful eye on deep tendon reflexes and respiratory effort for the patient receiving magnesium. All right, acid-base balance. So we talked about pH being the potential to accept more hydrogen. The higher the pH, the more acidic or more acid the fluid could accept. And so the higher the pH is alkalosis, right? It's a basic environment. The lower the pH, the less acid the fluid could accept. And so a low pH is an acidosis. And again, I think there's no substitute for just drawing this out and kind of creating some sort of picture in your own way that you like to draw it that makes sense to you. There's two main types of acids in the body. So carbonic acid is CO2, and that is a respiratory issue. Either you have too much of it from not ventilating well, or you have too little of it from overventilating. So anything that has to do with CO2 usually can be fixed with ventilation issues. Metabolic acids, though, are lactic and citric acids, and those are created as byproducts of metabolism. They typically are excreted through the kidneys. The problem becomes when the creation of these acids is in excess of the rate that the kidneys can excrete them. And then we end up with a metabolic acidosis that the kidneys can't buffer. So typically what happens is as soon as acids start to build up in the body, the blood will buffer them immediately. So blood buffers immediately bind to hydrogen. We have bicarbonate, we have hemoglobin, proteins, and phosphates that all bind to hydrogen. Potassium comes out of the cell, hydrogen goes into the cell. All of these things occur in an acidotic state. Additionally, since the body recognizes a change in overall pressure within the vessel from the acids, the respiratory rate will increase to exhale CO2. And this is kind of a quick compensation, but you can't maintain this for a long period of time. And then lastly, the kidneys secrete more bicarbonate and excrete more hydrogen. So this is slow, but it can last longer. So the three systems work together. The blood buffers, which some people refer to as bicarbonate buffer system, the respiratory system, and the kidneys all work together to kind of act as a buffer system to maintain acid-base balance. So what is an acid-base balance? What's balanced? So a normal pH would be 7.35 to 7.45. If it's lower than 7.35, it's acidic. If it's higher than 7.45, it's alkalotic or basic. So the first thing you want to do when you're looking at your blood gases is look at the pH. And I still draw arrows, it's fine, whatever you like to do. But just look at, is it high or is it low, right? So is it an acid or is it a base? What's my environment? Because that'll tell you, am I dealing with an acidosis or an alkalosis? The next thing you want to do then is look at the CO2 and the bicarb. So normal CO2 is 35 to 45. So it's pretty easy to remember the CO2 numbers because the pH is 7.35 to 7.45. CO2 is 35 to 45. So if it's a respiratory issue, those arrows were going to go in opposite directions. So respiratory, opposite, metabolic, equal. And we talked about that kind of that ROAM acronym. So draw your little arrows. You see with respiratory acidosis, the arrow is down for acidosis and up for the CO2 being elevated. And with respiratory alkalosis, the arrow is up for the pH being high and down for the CO2 being low. In both of those cases, because the respiratory issues, the bicarb is totally normal. And so bicarb normally lives at about 22 to 26 or 22 to 28, depending on the scale that you look at. If it's a metabolic issue, bicarb moves in the same direction on this arrow scale as pH. And the reason for that is that bicarb, when it's low, is an acid, and when it's high, it's a base, just like pH, versus CO2, when it's low, it's a base, and when it's high, it's an acid. So the arrow is moving in the opposite direction. So metabolic acidosis, both arrows are down. Metabolic alkalosis, both arrows are up. So what causes these kind of things? So respiratory acidosis is oftentimes caused by respiratory depression, CNS depression or trauma, drugs or alcohol, COPD, and it can be caused by pneumonia initially, but if you're hyperventilating, then respiratory alkalosis is also possible with pneumonia. Respiratory alkalosis itself is usually just caused by hyperventilation, and that can be caused by pain. It could be caused by fear, anxiety. So usually if we see hyperventilation, it's a compensatory mechanism for an acidosis, but sometimes we see it as strictly just hyperventilation that exists on its own. Metabolic acidosis is usually caused by diabetic ketoacidosis, shock, renal failure, and metabolic alkalosis is caused by things like sodium bicarbonate overdose, prolonged vomiting, and NG suction or drainage. So if you can remember this chart and draw it out, practice it, just keeping in mind of the respiratory is always going to be opposite in terms of the directions of the arrows from the CO2 and the pH, and metabolic is always going to be equal. That might help. So let's practice. First one, 19-year-old male brought to the ER with a femur fracture. Upon arrival, vital signs are 98.7, 110, 24. Blood pressure 117/63. His SAT is 97% on room air. He's very anxious and complains of tingling around his mouth and his fingers. We do a blood gas, and his pH is 7.48, CO2 is 32, and his bicarb is 24. So thinking about our pH, it's greater than 7.45, so the arrow goes up. The CO2 is normally 35 to 45, so it's less than 35, so the arrow goes down. And the bicarb is usually 22 to 28, so the bicarb is equal. So I have one up, one down, and an equal. So respiratory is opposite. So I have arrows that are moving opposite, so it's a respiratory problem. And then I go back to my pH, and my pH tells me that it's alkalosis, so it's a respiratory alkalosis. So what happened here? So this patient was in pain, he was hyperventilating, he blew off too much CO2, and because he created an alkalotic state, the calcium started binding to the albumin, and he actually developed this little transient hypocalcemia, which gave him the paresthesias around his mouth, nose, fingers, and toes. And if he kept going, he was going to start getting this carpal pedal spasms, which are tetany from the hypocalcemia from the respiratory alkalosis. Now you know. Okay, next one. 40-year-old woman with diabetes has been admitted for a skin wound. Upon admission, her vital signs are temp 101.9, heart rate of 124, respiratory rate of 22. Blood pressure is 140/86, and her SAT is 94% on room air. She's complaining of severe thirst and frequent urination. So we get a blood gas on her. Her pH is 7.28, CO2 is 30, and bicarb is 18. So the first thing we do is look at the pH. It is less than 7.35, so the arrow goes down. Then we look at the CO2. It's less than 35, so the arrow goes down. And then we look at the bicarb, and it is less than 22, so the arrow goes down. So now I have arrows in all three, but but I don't have any arrows that are pointing in an opposite direction. All three are pointing down. So metabolic, the arrows are all equal or pointing in the same direction. So this is a metabolic issue. Now I go back to my pH. It's 7.28, so it's an acidosis. So this is a metabolic acidosis. But because I have arrows on all three, it is partially compensated because my pH is not normal yet. So it's a partially compensated metabolic acidosis. Don't worry too much about the partially part yet. So just keep in mind of which way your arrows are moving. So why does this one have compensation where the first one didn't? Well, the first one was acute, right? So we talked about the guy had just broken his leg. He was hyperventilating. There's no way that the kidneys could have done anything that quickly. Versus this lady has a skin wound that's been infected, and it's probably been infected for a while, and she has developed, as a side effect of her skin wound and infection, probably DKA or HHNK. So she has developed a metabolic acidosis that had time to develop the compensation as well. So I hope that makes some sense. I mean, I know that the respiratory system is a little bit faster, but you can see that her respiratory rate is elevated, but it's elevated enough and long enough that she has a CO2 of 30. All right, keep practicing, keep trying. You can do this, and let me know if you have any questions. Thanks for watching.